Welcome to the Duke Spine Institute and our live stream. We're getting ready to start our first surgery for today. This patient is traveling to Duke Spine for the Duke laser disc repair, which he has several herniated discs in his back. And the herniations are at L3-4, L4-5, L5-S1. Shot. We're going to be using the X-ray to guide us to get in there and first gain access to his disc using a needle. Once we have the access and a safe corridor to do the surgery, we'll proceed with the endoscopic part. All right. I'm inching my way down a little bit lower. I always start with L5-S1 because that is the most difficult level to get to transforaminally. You're doing great. Lay still. Just don't move. Shot. So you can see we're approaching the facet joint there. And I'm going to have to redirect and go a little bit more laterally. Shot. Since L5-S1 is the most challenging disc to get to, that's why we start with that. It's going to set our entry point for the other discs. We're close, still not quite there. Shot. Getting closer. Just about there. You doing all right? All right, everything's going well here. We've started, and we're going to put you to sleep in just a few minutes, all right? Let's get an AP view. So we're going to use two views, AP and lateral. AP is front back, lateral is from the side. And we're going to use those two views to, number one, make sure we're treating the proper levels of discs, and number two, navigate. So getting from point A to point B. In other words, getting from the outside world here to the annular tear where his pain's coming from and the herniation. All right, very good. So far we're making really good progress. Shot. Just about done. Are you okay? Yeah. All right. Sorry you have to be awake for this, but I do need your help. You're doing great, by the way. So we're right at the back of the L5-S1 disc at this point. Are you comfortable? I'm going to give you a little more numbing medicine, all right? You just tell me if it's uncomfortable, and I'll give you more numbing medicine. Okay? Deal? So you can see, so far, it's a bloodless surgery. There's really no blood loss with this surgery. We'll lose a few drops, that's it. All other types of spine surgery, they lose a significant amount of blood during the surgery. Spine surgery can be so bleeding during the surgery, so bad, that you have to do a transfusion. But not with the Duke laser disc repair. We never have to do transfusions because we don't lose more than a few drops of blood, which is always good for the patient and good for the anesthesiologist. Keeps the anesthesiologist young. Full of hair. Blood loss is one of those things that, you know, generally we like to avoid. However, with open back surgery and open neck surgeries that are of the spine, you're going to end up having blood loss. And with a lot of spine surgeons, that blood loss can be quite significant. Shot? So right now I'm aiming for the back of the disc where the herniation is. And L4-5 is particularly bad. Of the 3 herniated discs in his back, it's the worst. Are you okay? All right, let's get an AP. So once again, we're going to go from a side view to a front back view to navigate. That's perfect. The tip of that needle, will you show that to them, Jordan? This is the L4-5. We're going to go on both sides at L4-5. You can see the tip of the L4-5 needle is just at the back of the disc. All right? How come we're getting so much graininess like that at the first pulse? Are you just not holding it long enough?
The tech lock is automatic, so it's changing from
Shot?
to
I can feel the herniation, by the way. I mean, I've been in it since we entered the foramen. It's huge. How long have you had your back pain for?
Off and on for 30 years.
Off and on for 30 years. Sorry to hear that. Wouldn't it be nice that it's going to go away today?
We're going to make it go away.
Absolutely. I have no doubt about that. Do it all the time. Very consistent.
He has a great attitude about it, too.
Yeah. Where are you from?
Iowa.
Iowa. You all hear that? He's from Iowa. I thought we stopped taking patients from Iowa. I'm just kidding. We have a lot of patients from Iowa. It's funny. We have these geozones we get a lot of patients from. Don't ask me why. We don't do any Google pay-per-click marketing at all. All we do is organic content development on our website, and that's it. We don't do any paid advertising. Spine, zero. All right, we are now at L3-4 on the right. So somebody may be asking, Dr. Dukmajian, why are you going from the right side? We go on the side that the patient has leg symptoms, and if there are no leg symptoms, where we find weakness or numbness from a pinched nerve. Because the best chance of unpinching a nerve is when you go from the side that the nerve is pinched on. So if the patient has weakness on the right side in their right leg, we want to go on the right side in the lumbar spine to unpinch the nerve. The reason for that is quite interesting. That's because the most common cause of pinched nerves in the lumbar spine is something called lateral recess stenosis. And unfortunately, the vast majority of spine surgeons don't know this. So they'll look at an MRI. I'm going to give you some more numbing medicine, okay?
Yep.
Just bear with me. A little stick and burn. You're doing fantastic, by the way. We're almost done. We're going to put you to sleep soon. Lateral recess stenosis, most doctors don't even know what that is. And yet it's the #1 reason for leg problems, pinched nerves going into your legs. It's a shame because it's very important. If you don't know about it, you're not going to look for it. If you don't look for it, you're not going to find it. If you don't find it, you can't fix the patient. So the #1 reason for failed back surgery is persistent lateral recess stenosis. This is not my work. It was documented years ago. Unfortunately, I told my son this the other day. I said, you know what's going to be the most important commodity of the future? He said, what? I said, knowledge, true knowledge, like books, scientific books. Because there's so much false information out there right now in the virtual world that, and that's just getting to be more and more false information. And the textbooks that I grew up with in medicine at USC, those pathology textbooks, histology textbooks, I'm going to be honest with you, they're very hard. They're very hard to learn because they're so full of important information. And the new generation of students doesn't want hard, they want easy. And so, unfortunately, the academic curriculum is changing it to accommodate them, you know, and make it easier for them to pass their tests. Well,
It's on their cell phone now.
yeah, but it's all misinformation. No true good science can be simplified to the point of, you know, making it easy. Medicine is very selective about who it accepts into the field for a reason. You doing all right?
Yeah.
And the reason is simple. You need to be very smart and able to process and remember tons of information related to the human body. And you learn, gross anatomy, you learn histology, you learn pathology, pharmacology. You learn all that stuff in a concentrated amount of time. And if you're not given the right information, then you're never going to have a solid foundation to basically change medicine and make it better. And there's so much financial, there's so many companies that are just interested in monetizing medicine, not for the patient's best interest, but for their own. Venture capitalists, private equity firms, they're all investing in healthcare because they want to get big payments. And so there's this push in healthcare, unfortunately, for things that are not the truth anymore. Shut. And that concerns me. So I told my son, value and cherish the scientific medical textbooks, because that's going to be a very important commodity. People don't care about books anymore. They just throw them away. Garbage. But the old books from the 80s, the 90s, the early 2000s are going to be the truth of the future generations. And if we don't take care of that knowledge, it's going to disappear. It's literally going to disappear. And it's going to be replaced with fake knowledge, false knowledge, which you can't fix people with false knowledge. You understand? I see it in spine. Huge push for fusions and invasive technologies. You all right?
Sure, let me adjust.
We'll take care of that for you. Let's get an AP. For those of you watching, we've now placed the 4 spinal needles because we're fixing four herniations and annular tears. We've placed the 4 spinal needles, and we're ready to get started with the next phase of the surgery. All right, let's talk for a moment, and then after we do the discograms, we start putting the patient to sleep. Henry, will you run the video explaining how a spinal disc causes back pain?
Copy that.
All right. So he's had lower back pain on and off for 30 years. And I had a great talk with him yesterday. And I said to him, well, when your back pain goes away, is it because you're less active? You're not doing things? And he said, yes. I said, then your back pain never really went away. You just took it easy and made it go away. But your quality of life is no good, right? Because you're not doing anything you want to do. So back pain for 30 years. When I asked him, where is your back pain? Where do you get it? He showed me this area here in his back. Okay? All right. Are you comfortable? Are you having any pain? So there are basically 3 discs in this area, and I looked at the MRI, and all 3 of them, the L5-S1 and the L4-5, sorry if you can't see that, and the L3-4 disc. All 3 of these discs are right there. And I looked at the MRI, and he had basically an annular tear with a herniation at each one. And the L4-5, it was herniated on both sides. Actually, the nerves coming down, going into his legs, run right past that herniation. And the herniations are pinching the nerves on both sides at L4-5. Right side at L5-S1 and right side at L3-4. He also has a herniation at L2-3. You can see it. But that was outside of his pain area, and there's really no point in treating it right now. It's the least symptomatic of the disc. So we're going to fix these 3 today. Are you comfy? You having any pain? All right. No pain, he said. How bad is that on a scale of 1 to 10? How high?
6.
That's the highest it went, was 6?
Yes.
Is that where you typically get back pain? I couldn't hear him.
He said yes it is.
So he had 6 out of 10 pain at L5-S1. All right? And he doesn't have a lot of pain right now. He's saying, I don't have any back pain. So a 6 out of 10 is pretty significant for a man who currently today doesn't have back pain. All right, is that better?
Yeah,
Mm-hmm. We're going to place the first guide wire because we start with L5-S1. No pain now? All right. How bad is that on a scale of 1 to 10?
5, 6.
6. So I hope we don't have a 666 situation here. The next one cannot be 6. Is that where you typically get your back pain? Uh-huh. Yes, he said. All right. All right. So the next one is really the worst disc of all. So, are you comfortable? How bad is that on a scale of 1 to 10? 9. Thank God. 9 out of 10, right? Phew! Almost had a bad situation. All right. You get to go to sleep. And when you wake up, we'll be done, and that back pain will be gone. I like the patriotic nature of this patient. You can see. And we're not in France. So, all 3 discs cause his pain, but the main reason he's here is he's got weakness in his legs. He cannot cock up his foot or his toe, and he's got a very badly pinched nerve at L4-5. All right, we're going to get started. Let's go ahead and show the video as to why do discs in the spine actually cause back or neck pain.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
All right, welcome back. I was saying earlier we've lost probably a cc of blood, which is 20 drops. It's not common to lose much blood during these surgeries. These are relatively non-bleeding surgeries because we have a small incision. We're not going anywhere near big blood vessels. We're not traumatizing the body to the point that it wants to bleed. Bleeding comes from trauma. You traumatize normal blood vessels, muscles, tissues, they bleed. Less bleeding, less trauma. Our first disc will be the L5-S1. Through a right approach, we're already inside the disc. That looks pretty good to me. Let's see what we've got there. So we've just placed the endoscopic tube. We call it a tubular retractor. And it looks like we've got some orbital issues there. You see it? We're rotated. We may need to go in a little further, but let's see where we are. Let's take a peek. We're going to move the fluoroscope out. We're going to bring in the fluid adapter. And we're going to get started with our repair using a laser. It's called the Duke Laser Disc Repair. Let me show you the endoscope and camera. You guys see this? Let's turn on the light.
Lights on, please.
So, can you see this, Henry?
Yes, we can.
We have a high definition camera, endoscope, single port channel. Here's our fluid or irrigation. It's sterile, saline. And here's the light source. Turn on the light source. Very good. All right. Let's get started. Any questions?
No current questions.
Let's see where we are. Yeah. We need to go in a little bit more.
More?
Yeah, because the x-ray is rotated. So we're just at the beginning of the annulus. You should be able to go in, right? Wait, oh, yeah. Uh-huh. We're okay. I'm just going to bring it in a little bit further. That should be good. That should be good. Yeah, I just moved it in a sonometer. All right. We do the broadcast live so you folks can ask questions during the surgery, and you can actually see what we're doing. We are inside the L5-S1 disc on the right. You can see the blue stain of the degenerated herniation. A herniation in a disc is normally white. It's called nucleus pulposus. It's white. And you can see it on the endoscope as white when it's normal. The other things that are white include scar tissue.
We are 3 and 50.
Yeah, you're less powerful, right? It's less power?
Yeah, just like the last time.
Yeah.
It's up to you if you want to go higher.
We used to do 3-5.
Yeah.
So the white there is scar tissue that you're seeing, and it has a golden color to it, which is calcium. It's not normal to find calcium in tissues like this. You only find it in these tissues when there's damage, and that damage is from inflammation. As you saw earlier, there's lots of inflammation caused by the herniation within the annular tear. Our new website is coming along. Hopefully it's going to launch soon. The team that's building it with me, we've been meeting every week, several times a week, trying to finish it. It's incredible work in progress, and of course there's no other website to model it after. However, the content is all original because it's content that we've developed here at Duke Spine, information that we've discovered here at Duke Spine Institute. But it's going to be very informative for people who take the time to learn. Actually, we're even redoing our animations.
We have a comment and a question.
Sure.
This first comment comes from Sean Wilson on YouTube.
Yeah, Sean, before you give me the comment, see the blue? The blue thing? That's a herniation, okay? So I'm going to stop the laser and try to grab it out. I'll take the comment.
He said, "Love your work. I've been dealing with back pain and numbness for 17 years.
Sorry to hear that, Sean. We can fix that for you at Duke Spine.
And the question, it comes from Pardeep on YouTube. And they asked, may I share my reports?
You can share your reports, Pardeep, but we're not going to do a diagnosis for you over the air, or even on the YouTube channel or anywhere else, Pardeep. The reason for that is reports don't tell us what's wrong unless you have a tumor or a fracture or an infection. When you have back pain, the most common reasons are degenerative, and you have to have a physical exam to make the right diagnosis. So we offer you that opportunity, and everybody around the world can have that opportunity to get a diagnosis, what's causing their pain, and a recommendation for treatment. But you have to do it the right way, which is to do a consultation. We actually can share a link. Henry, will you type up dukespine.com, dukespine.com /VC for virtual consult. That's the link I would recommend, Pardeep. dukespine.com /VC for virtual consultation. If you do the virtual consultation, I will look at your MRI images, your MRI report, and be able to do an exam and figure out where your pain is coming from. But you can't do it just based on MRIs. It's not possible. I don't even waste my time trying. And there's nobody in the world that can do a diagnosis as well as I do for back pain. So you got the best in the world, and I'm telling you, you cannot do it without a physical exam. You know, a physical exam is essential. There's the tear causing all the pain. Look at the degenerated disc, the blue stuff, okay? A normal disc is white. That's blue because it stains with a staining agent, a dye that we use, a vital dye, that stains to acidic nuclear material. The only way to get acidic nuclear material is with degenerative disc disease. So the blue stuff is abnormal because it's staining blue. It's staining blue because it's abnormal. So the blue stain helps me identify the parts of the disc that need to be removed. There's no other surgery that does this, and we spend the most of our time here actually debriding the annular tear. The debridement is the key to eliminating back pain. It also debulks the herniation, because the herniation is the nuclear material pushing through the annular tear. Were you able to get that link up for Pardeep?
Yep, all good.
Good.
And we have another question.
Sure.
This comes from Sarfraz on YouTube.
Before you do, see the pink stuff? That's the inflammation right there. That comes from, if you want to get a picture, did you save that? Go ahead and save that short segment. Oh, by the way, Henry, I asked you in an email, are you saving this in a special case folder?
Yes, we are.
I need to see that when I get out, okay? I need to see where it is,
Copy that.
so I can see what's in there and kind of review it. Because we're starting to write more papers, and I want to put some of these pictures in there in the papers so people can see what we're talking about. Sorry, go ahead.
The question from Sarfraz is, what is the approximate cost? I have an L5-S1 issue.
Yeah, so no problem. The procedure starts at $15,000 US, 15,000. And it depends on how many discs we're fixing, and it depends on the size of the herniation, the location. The only way to know your cost is to do a telemed visit, a consultation. And then we can give you the actual cost. The nice thing, when we give you a cost, it's a bundled cost, meaning there's no additional hidden costs. It is the one cost you have to pay, and you're not going to get a surprise bill from us or anybody for additional money. Look at that right there. This is it, Henry. Again, we've hit the jackpot the last couple of surgeries. That is inflammation tissue. I'm going to try to sharpen up the image. I think that's the best I can do. What do you think? Can you do a few screenshots or something, or save this segment?
No problem.
Look at that pink tissue right there. That is where all the inflammation is happening in the annular wall. This is what's causing all the pain. If you remove it, you get rid of the back pain. It's beautiful. I hope you put this case in the, in that special folder, so we can take that pictures and video and incorporate it into our publications in the future.
Copy that.
All right. I think I answered the question. So everyone wants to know cost. Here's the thing, folks. I don't know what you need done until I see your MRI. So the results that we get at Duke Spine are cures. We cure back and neck pain. Why? Not because we fix one disc, but because we fix all the discs that are causing pain. And you may think you have only one disc causing your pain, but you could be wrong. And I told you, the reports are wrong. The MRI reports are wrong 99% of the time. They cannot identify the source of back pain. So the only way to identify the source of your back pain is through the consultation. Once you have the consultation, I'll know if you truly have one disc, L5-S1, and that's the cause of your pain. But if you have more than that causing your pain, and you pay for the L5-S1, and you're not going to get rid of all your pain. I hope you understand that. The MRI reports don't tell you where your pain's coming from. You need an expert like me to do that, and I cannot do it with an MRI report alone. Unless you have perfectly normal discs everywhere, you have a perfect spine except for the one disc, which I don't believe that to be the case until I see it myself. Because a lot of herniations are missed by the radiologists. And if you're coming to Duke Spine and paying for surgery to get rid of your back pain, and you have two discs causing your back pain, but the radiologist didn't say anything about the other disc because it was small herniation, those small herniations can cause tremendous pain. They can be far more painful than the big herniations. So just be aware of that. All right, there's some more. Again, that's the tear right there. With the pink stuff is the granulation tissue. This is a very important picture here. Does it look sharp and clear to you?
Yes, it does.
All right. And I want to get a shot with the laser right there so you can kind of see what we're about to do. This is the annular debridement. Only the Duke Spine Institute does this. The only place in the world doing this surgery curing back pain. Why is that important? Because there's a lot of people who will try to tell you, surgeons try to tell you they do laser surgery or they do endoscopic surgery, but they don't do what we do. We're the only place in the world, and we're the only one that consistently cures back pain in patients when it's coming from discs. All right, have you played the video on how does the Duke laser disc repair actually work?
Not yet.
Let's do that so our people can see it.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
Welcome back. As you can see, we're lasering away at the annular tear and the inflammatory tissue. All of this scar tissue here is from years and years of inflammation. You could see it all. The blue stuff is the nuclear material, nucleus pulposus. And we're trying to clean out as much of this as we can because it doesn't belong here. We're not inside the nucleus pulposus. Yet, that is nucleus pulposus. So how did it get there? It got there because it herniated out. There was an annular tear, you saw that, and the nuclear material squeezed out through the tear and got stuck in the tear, causing inflammation. And I showed you the inflammation. This surgery is the only surgery in the world that actually treats that tear and the inflammation.
We have a couple questions.
I'd be happy to take your questions.
This first one comes from Austin on YouTube. And they ask, regarding the anesthesia, what has the patient received and what are they receiving now?
Sure. Great question, Austin. Thank you for asking. So this surgery, the patient is laying on their belly. We're going through their back. And up by their face, they have the anesthesiologist, Dr. Berndes. And Dr. Berndes has got a face mask on them where he's monitoring oxygenation of their blood as well as monitoring the output of carbon dioxide. And he's monitoring the end-tidal CO2 to make sure they're ventilating adequately and oxygenating adequately and monitoring their blood pressure. So generally you don't have to give much for blood pressure, right? Just propofol? Just the propofol, because once you give the patient a sedative, propofol makes them sleep, then the blood pressure usually goes down. So I know some nurses who actually treat blood pressure with propofol in the neuro ICU, which they really shouldn't do. And I'm not saying that that's ongoing today, but that's always a battle with the nurses, because when you have a neurosurgery patient with blood pressure issues, they like to snow them with propofol to get their blood pressure down. And point is, propofol is really good at lowering blood pressure, but the deeper the patient gets, they could obstruct their airway and stop breathing. So it's a very delicate procedure. We don't have a tube down the throat. This is not general anesthesia. This is what's called twilight anesthesia, where they're sedated but no tube. The advantages of no tube are you're not traumatizing the vocal cords or the airway, so you don't get all the problems of intubation, but you also have a harder time monitoring the breathing and controlling the airway. And if the patient vomits, they could aspirate. So there's pros and cons to each technique. The reason why we use twilight sedation is I need my patients awake in the very beginning of the surgery. So they can tell me if I'm getting too close to the nerve, and they can tell me, how painful the discs are that we're fixing. We do a discogram called an evocative discogram. So that's why we need them awake and not under general anesthesia. This is taking a long time. Why? Because all this 30 years of scar tissue, you're seeing it right there. You can see the blue stuff. This is another good picture, beautiful picture right there. And what you're seeing is the annular tear with the blue stuff stuck in it and the reaction of the body, all this scar tissue that was formed from years of inflammation going on. So it's all totally abnormal. And we're cleaning it, and when we're done, it's going to heal with collagen, but no nuclear material stuck in it. So there will be no more inflammation. We're stopping the inflammation. All right, next question.
Next question comes from Guido on YouTube.
Guido?
Guido.
Hello, Guido. Welcome.
And they asked, are there any neurosurgeons in Europe who operate like you?
No. Guido, there's no neurosurgeons in the world that operate like me. And the reason is we developed this technology here. Now, I will tell you, the endoscope, the tube, the whole concept of endoscopic surgery is not unique to Duke Spine. I mean, that's all around the world. China, Korea, Germany, probably Italy, I'm sure. Maybe where you're from, I imagine. But the laser application, you see the laser down there I'm using? That laser nobody else uses. We started using the laser here 16 years ago. And the laser is the key, because I'm going to show you something right now. The tools that the other surgeons have are grabbers, just like this. You see that?
Thank you.
The grabber, you see this grabber down here? I'm going to show you right now. You see the grabber?
Yes, we do.
That cannot remove this. It can remove a little bit, but it cannot clean the tear. You can remove some of the herniation, but you cannot debride the tear. So even after I finish with the grabber, okay, there's still going to be a problem that's causing pain, and that's the tear. The laser is the only tool that debrides the annular tear. That's what makes this surgery special. The grabber is what all the other surgeons use, but that's why they can only remove part of the herniation, because they only use a grabber. Okay, they don't use the laser. The laser is very expensive. It comes from, this one is made in Israel. It's the best laser, I think. There's other lasers in medicine, but this is, in my opinion, the best for this application. Everything is FDA approved by the United States FDA. People ask me, is this laser surgery FDA approved? Yes, it is. Everything we use is FDA approved, just like any other surgery. All right, we're just about done. About 30 seconds left. But I'm sorry, Guido, you're going to have to come to Florida for your surgery, which is not a bad thing. You might like it here. Where is Guido from? Is he from Italy? I can't.
I would assume so.
Yeah, I don't want to assume, but from the name Guido, it's an Italian name, I think. But it's lovely to have you on the broadcast, Guido, and everybody else. Any other questions?
No current questions.
Excellent. All right, just about done. I'm going to show you some stuff, and then we're going to get out of here. But this is like a big herniation, and it's been here a long time. So look over here. You can see the end plate of L5. That bone right there. You see the pink thing? That's a bone. And that's the bottom of the L5 vertebral body. It's called the end plate. It's what abuts the disc at L5-S1. So the disc is between two bones, the L5 and the S1 bone. And that is the L5 bone. All right, almost done. You can see a little bit of fat in the epidural space at 12 o'clock. I'm looking, go ahead.
We have another question from Reese on
Yeah,
YouTube.
before you do it, I just want you guys to know, I'm actually looking for what's called the traversing nerve root. If you know what I'm talking about as a surgeon, you know what I mean. There's a nerve that runs across at 12 o'clock. It goes from around 2 o'clock over to 10 o'clock. And that would be the S1 nerve root, okay? And I'm making sure that I don't damage it. It's right outside the tube. If I lift the tube a little bit, you'll see it. You should be able to see it, but it's going to be in the fat. Right now, I'm kind of torquing my tube. I'm pulling it laterally towards me so that the base of the tube, where you're seeing the fenestration and the laser, that part is moving towards the midline. I want to get as medial as I can because I want to decompress the nerve root and get all the tear that I can get with the laser. Before you go to the question, I do want to say I get a lot of questions about how much of the herniation are you taking out? The answer is around anywhere between 50 to 90%. There is no surgery in the world that gets 100% of herniation. And people ask me, should we get an MRI after surgery? The answer is no, because the only reason we get MRIs is if it's going to change how we treat the patient. And I'm not going to change how I treat the patient based on an MRI. I'm going to change how I treat the patient based on a diagnosis. So if the patient has an issue for some reason after surgery, I need to make a diagnosis. What's causing it? And an MRI doesn't tell you everything. So you need to use your brain, not an MRI. That's why I emphasize the clinical diagnosis so much. In this field of spine and back pain, it's all clinical diagnosis. The MRI is just a tool, but in the end, it's a clinical diagnosis. Okay? If you're looking for a tumor, you get an MRI. You don't ask the patient, do you have a tumor? The patient won't know. If you are talking about back pain, well, there is no tumor. It's back pain. The patient has to tell you where it's coming from. So it's a completely different dynamic when it comes to solving back pain than it is to treating spine tumors. Okay? And that's the problem, is that everyone thinks this is a structural problem with the spine. Spinal stenosis is a structural problem, but back pain is not. Back pain is an inflammatory problem. All right. Just about done. You can see the fat at 12 o'clock, and it looks like I've just got a little bit of foraminal ligament, and I'm just trying to get as medial as I can. Medial means towards midline, because the more I can get out of this herniation, the more relief he's going to have in his leg. I'll be honest with you, this is a lot worse than it looked like on the MRI. So the MRI doesn't even tell you everything. We rely too much on MRIs for back pain. You absolutely have to have an MRI, but I can diagnose back pain source without an MRI most of the time. I need the MRI to treat though, to confirm the treatment, okay? All right, let's go to the question.
Question from Reese is, how quickly do patients return to normal daily activities?
Yeah, how quickly do patients return to normal daily activities? Tomorrow, the next day, basically. Less than 24 hours, Reese. Now, of course, if you're a jiu-jitsu instructor or a professional athlete, you're going to have to give your body time to heal. So, but normal daily activities, work, driving, shopping, tomorrow. This is outpatient surgery. This patient's going to go home an hour after the surgery is done. So we'll finish the surgery in an hour. They will go home an hour later. And when I say home, of course, he's from Idaho. Sorry. He's from out of state, so he's got to go to a hotel. And he's going to spend the night in the hotel with his wife, who's here as well, and then he's going to leave tomorrow afternoon and fly home. 80% of our patients now come from other states and other countries. We get people from Europe, they fly here for the surgery. We get people from Canada. We get people from South America. All over the world, they come for this particular surgery. And they go back to work they go back to regular things the next day. The only restriction is lifting weight. You cannot lift heavy weights right after surgery. You have to give it time for your disc to heal. And you cannot do contact sports, football, rugby, gymnastics. You've got to give time. Not that gymnastics is a contact sport. There's a piece of herniation. But you can't do the type of sports that are going to put a lot of stress on your lower back. You have to let the disc heal. These are all pieces of herniation. And you can see there's still some herniation left we need to grab out. Great questions from our audience.
We have a couple more questions. Sure. This next one comes from Sean Wilson, once more, on YouTube.
All right.
And they ask, have you ever treated someone who had lights in their eyes and numbness in the hands due to neck pain?
Yeah. Well, the lights in the eyes are called visual scotoma. Visual scotoma. S-C-O-T-O-M-A. And a lot of times they're due to migraines. Most commonly migraines. Could be seizure activity. But the triggering event of your migraine could be the pain in your neck from the herniation. So it's 100%. We see patients all the time with headaches and neck pain together. So the headache comes from the inflammation, which I showed you earlier on the video. And that inflammation spreads from the back of the disc where the tear is, which I showed you, and it spreads onto the dura, or covering around the spinal cord, and eventually goes up to the brain. So it can definitely cause that type of problem. But basically, it sounds like you're getting a migraine triggered by your neck pain, because migraines have triggers. Great question. This disc has taken a long time, a lot longer than I expected. But the good news is we're getting it all cleaned out. There's a lot more damage than I expected as well, based on the MRI. Hey, can I give you guys some advice? If you've got a disc problem, get it fixed earlier than later, because the longer you wait, the more damage that's happening, the harder it is to heal, and the longer your surgery will be. So just some advice.
We have another question.
Yep.
This comes from Austin, once more, on YouTube.
Excellent.
And they asked, what got you into the specialized spine surgery, and why hasn't it caught on with other spine surgeons despite your high success rates?
Yeah, great question. We get this question every week. So I've got my answer for you, because I've had a lot of time to think about it. We get it all the time. You know, I asked myself the same thing. I mean, can't be the only American surgeon that knows about endoscopic surgery. But the answer is very complex, and it's all about money. It's what it really comes down to, money. So endoscopic surgery like this is a lot less expensive than fusions. And because it's less expensive, it pays the surgeon less money. Surgeons make the most money doing fusion, and they make the most money doing multiple fusions. The more discs they fuse, the more money they make. And the more artificial discs they put in, the more money they make. And there's a lot of, all of this is driven by the device companies, the companies that sell the metal. And they have now gone into our universities where the surgeons are trained, and they've basically taken over the agenda of education so that they control the entire educational agenda in neurosurgery training programs, orthopedic surgery training programs, to where they are influencing every decision made. They control the head of spine surgery at every university. Those doctors are on their payroll, and they're the ones in charge of the surgeries that are being done for spine surgery. So this surgery doesn't pay peanuts to the surgeon. I don't make much money. I make $1,000 for a surgery like this. But if you do a fusion, instead, I'll make $15,000. The reason I do this is because it's better for my patients, the results are better, it's safer, the return to work is faster, the return to normal activities is faster. So this is the future of spine surgery. You're watching it. But I can't make that happen myself. It has to be the patients demanding it from their doctors, because the system is broken. It's completely out of control. So there's a lack of education. There's a lack of reimbursement for the surgeon. They don't get paid much, so they don't want to do these surgeries. And there's just an overall control of the entire spine industry by companies that are making around $50 to $100 billion a year in the U.S. alone selling the metal. That's the problem. So they don't want to lose that business, because how much metal do you see me putting in? Zero. I don't put metal in. So they're going to lose $100 billion in the United States alone overnight if every surgeon switched. So there's a huge financial incentive by those companies to preserve the fusions. There's the nerve, by the way, right there. That's the L5 nerve root on the right. You can see the vein on top of the dura covering the root. And there's where the herniation was. You can see how it was pushing on the nerve. And there's a little vein right there. You can see it, 12. All right, we're done here. Great question. So you have poor reimbursement for surgeons. We don't make much money. And who chooses the surgery? The surgeon, right? So when you go to the surgeon and say, hey, what do I need to do for my back or neck? The surgeon tells you what to do. You either agree or you don't. But in the end, the surgeon's only going to do the surgery they want to do. Well, they want to do surgeries that pay a lot. They got bills to pay. So they're going to choose, unfortunately, their money and themselves over you. And that happens all the time. I've been watching it happen for 20 years, 25 years. And it's not going to change unless you folks change it. You've got to demand your surgeons do the right surgery. So here's how it works, okay? And I don't want you to get the wrong idea. The wrong idea is that they make money doing one surgery. They don't. It starts with you go to the doctors. They tell you take some pills. They're making money prescribing pills. Then they tell you try some shots. They're making money on the shots. Then they tell you go do a laminectomy or a discectomy. They're making money on that. But more importantly, once they do that laminectomy, it's the kiss of death. They've got you trapped. Because once you get a laminectomy, discectomy, you're coming back for more surgery. It's guaranteed. And more pain management. So then you go do some more shots. You do some more pills. You do some therapy with their therapy group. Then you come back for more surgery. Basically, you're going to be wrapped in for 20 years, 30 years of pain management, going between pills, shots, spinal cord stimulators, morphine pumps, fusions, and never getting out of pain because they don't want you out of pain. Duke Spine Institute here, we're completely different. We want your pain cured so that you don't come back here anymore because we got enough patients to take care of. We got a lot of patients and we don't need repeat business. We want what's best for the patient, which is get fixed and then go on with your life as soon as possible. So you're not going to find many places in the world with that philosophy. As a matter of fact, you might only find 5 of them in the entire world. That's what makes us special, is that idea of doing what's best for the patient, not what's best for us, has driven all the advancements we've created at Duke Spine over the years. Advancements in techniques of treating and diagnosing back and neck pain to where we're doing what's best for the patient every step of the way. And you're not going to find that elsewhere because what's best for you, the patient, is not best for, that's fine. There's usually nothing there. We're fine. What's best for the patient is not what's best for the doctor, okay? What's best for the surgeon, and by the way, the hospital too, because the hospital makes a lot of money off of doing spine surgeries like fusions. I'll take care of it. Let me do it. Okay, so the hospitals make $100,000. I need a, okay. Hospitals will make $100,000. The surgeon will make $10,000 to $15,000. And then the companies that sell the screws and rods, they're going to make, Sean? They're going to make about, $10,000 to $20,000 or $30,000. So you got hospitals making 100, surgeons making 15, and the companies selling the implants making another 15 to 20. So that's like $150,000 on average, basically per surgery, that's being made for complicated spine surgeries, complex spine surgery. Okay, so they don't want to give that up. That's the answer. There's a lack of interest in less invasive surgery because there's no metal involved. There's no big dollars. And it's just going to be that way for a long time until you folks demand that they stop doing what they're doing.
We have another question.
Yep.
This comes from Austin once more on YouTube. And they asked, have you considered practicing at an academic institution and educating future surgeons regarding this type of spine surgery?
Yes, I have, as a matter of fact. I have, pull it back. I have considered, as a matter of fact, I am a faculty member of University of Central Florida School of Medicine. Okay, that's in Orlando, Florida. You can take it out. And I am a neurosurgery faculty. Problem is, the medical school there is new, and they don't have a neurosurgery residency program. When trying to work with the dean of the medical school, Dr. German, we had meetings. She wants to create a spine and neurosurgery training program. She wants me to be involved. So we're in talks because I live in Florida, and I'm not just going to move. I don't care if Harvard calls me and says they want me to head up their spine department. I'm not going to go. I'm not interested, okay? And you go to a big academic center, and you're going to have politics. I'm going to have to deal with those surgeons that are on the payroll, making millions of dollars a year from the big companies that support those centers. For example, take Harvard. They make tens of millions of dollars a year from Medtronic, who makes the screws, rods, cages, okay, and other implants. They make tons and tons of money because those companies like Medtronic, they'll make $100 million a year off of Harvard's spine program and orthopedic program. And then they'll give 10 million back to the department chair, the chairman, not to the chairman personally, but they'll give it back in educational grants and supports for the residents. So they're giving a kickback of 10 million, let's just say 10%, to the academic center, which I can't give them a kickback. I don't have any money to kick back to them. I'm not going to. And besides, it's illegal. In my opinion, it's immoral and illegal. So these academic centers are on the take themselves, and their chairmans are controlled by these implant companies. I told you that they've infiltrated completely, and they've captivated the academic centers' programs, and they control what's being taught. So it's not like me just, I waltz in and say, hey, I've got the most advanced spine surgery in the world. I can cure back and neck pain, take me. And they're going to embrace me like the prodigal son returning. They're going to stick knives and swords in my body and try to kill me. They'll try to destroy my reputation, destroy my license to practice. They'll do everything they can to destroy me. Oh, it happens all the time. So how am I going to fix that kind of a system that's vicious and malicious and very hell-bent on money? You can't. The only way I can fix everything is with massive support from people out there who want change to happen for the better. People like-minded, people like me. And my staff here understand, and I think they share my philosophy. Otherwise, they would have taken jobs elsewhere long ago. That's my phone. But the problem is for me to change an academic university's, politics is like me naked taking on 5 raging bulls that want to gore me, and I'm running around a bull ring naked with nothing to hide behind, okay? That's what it's going to be like. Trust me, I've been in this situation before. Just coming to private practice in Florida at a hospital, the orthopedic surgeons here and the whole community, they saw me coming. And of course, I was very well trained. They know that. I trained at the University of Florida in Gainesville. It was the top neurosurgery training program in the world at the time, in the 90s. So they were very intimidated and afraid of what I was bringing. And they knew I was going to bring competition. And I knew that there were plenty of patients, so there's no reason for us to fight. But they attacked me as soon as I showed up. They tried attacking me before I showed up. And they don't do it in an obvious way. They don't show up with a sword in their hand. They actually show up with a dagger behind their back and a smile on their face, offering help. And as soon as you're not paying attention and looking at somewhere else, they'll stick that knife in your back as far as they can to kill you. So I've been through all that for years. I had to deal with politics. And that's just in a community hospital in the middle of nowhere, the United States. Imagine what an academic center is going to be like. So, am I not going to try? Of course I'm trying, but I'm doing it in a new medical school in Orlando where they're open-minded and they have the vision of being cutting-edge, state-of-the-art, top services in the world at that medical campus in Lake Nona. And that's what I'm trying to do. And it's either going to work or it's not. But I'm not going to lose sleep over it, okay? Because every day I'm fixing people's pain. And if you want to get fixed, you come here at Duke Spine and you get your back pain and neck pain fixed. It's that simple. I will train the future surgeons here at Duke Spine. I don't need to go to Harvard or Columbia or Yale or Hopkins or anywhere. I will do it at Duke Spine, and I will control it and make sure it's done right. And there is no politics that take over and circumvent what I set in place to make sure patients get the best care in the world. That, to me, is my top priority. My philosophy of medicine is always do the very best for the patient. And that's for the patient, not for the surgeon, not for the hospital, not for the insurance company. I am loyal to my patients. All right, next question. Great questions, by the way. Great engagement today off social media. Thanks for asking and being.
No current questions, but we do have a couple comments. This next one comes from Vichithra on Facebook.
Hi there. Thanks for joining us. Bitchifala.
And just to put in the sentence, they said, "Hello, I am 71 years old with a pension, and please help me. My right leg is weak and has numbness. I got drops foot pain on my right leg, and I live in South Africa."
We can help you, but you're going to have to come to Florida. Why don't you put the link again? Go ahead and respond to that person and put the link. It's dukespine.com /VC for virtual consult. Use this link. Upload your MRI images. And I will meet with you even though you're in South Africa. By the way, I'll be in South Africa this summer. I've never been to Africa. My family originally is from Africa, my father's side, from Egypt. So I'm going back to Africa this summer, and I will actually be in South Africa.
We have another comment.
Yes.
This comes from Guido, once more, on YouTube.
Hello, Guido.
And they said, "You are right. Even in Italy, it is the same. Neurosurgeons want to put metal cages in your spine."
Yes, Guido, it is. That's because the same companies that control what happens here to patients with metal, they're in Italy too. They're making money internationally. They're international. They're called a multinational company. Look up Medtronic. Look up Johnson & Johnson. Look up Nuvasive. Nuvasive. Look up Alphatec. Look up Globus, Globus, Globus. These are multinational companies that sell metal in every country. And they use other countries, like third world countries, as experiments, places to do experiments on the people. They get new products. They don't bring it to the United States. They first do studies on the people in other countries like South Africa because, you know, the government allows them. They pay the government off, and then they can kill people with their techniques and their treatments, and they don't get in trouble. It's horrible what's happening. Honestly, people are so unaware, and that's why I do these broadcasts, to make people aware of the truth. They deserve to know the truth. I would want to know the truth. If I was somebody suffering in pain, I would want to know the truth. And people deserve to know the truth. All right, just about done. So I believe it's my job to bring you the truth when it comes to spine. It's my mission to bring you the truth and also to fix people.
We have a few more questions.
Sure?
This next one comes from Sarfraz on YouTube. And they asked, "Do you know Arabic?"
Do I know Arabic? No, I don't, but we have Arabic-speaking people here at Duke Spine. So if you know somebody who is Arabic-speaking, we have people that work here that speak Arabic. One of them is right here, Omar, right? Omar speaks Arabic. He's standing here next to me in the operating room. And he can help people who speak Arabic. We also have Richard, who speaks Arabic, Shamoun, and we have several Arabic-speaking people. So no problem if you're interested. What I would say is do the virtual consultation, and we'll get an Arab-speaking person to talk to you, okay? One of our staff. Now, myself, I don't know. I only know a few words in Arabic, and you don't want to hear them. They're not good. I grew up, I'm Armenian, and Armenians, my family, I told you, is from Africa, from Egypt, but my father spoke Arabic fluently, and my grandparents spoke Arabic. However, I, growing up in the United States, never learned Arabic, and I learned just some of the dirty words, the curse words, from my cousins. So I can curse in Arabic, but I cannot have a conversation in Arabic. I'm just being honest with you.
Our next question comes from Donald Jackson on YouTube. And,
Okay.
and they said, "I have a fusion from my pelvis to my shoulder, and where they stopped at my shoulder and put screws in, I have a broken vertebrae. What do I need to do about it? I am just outside of Minneapolis, Minnesota. I'm 52 years old and in an enormous amount of pain.
And sorry, Henry, I heard that, but I didn't understand. Where exactly is the pain now? Is it in the shoulder or in the spine?
I have a fusion from my pelvis to my shoulder, and where they stopped at my shoulders and put the screws in,
okay.
I have a broken vertebrae.
All right. Folks, I hope you're hearing this. This is such a sad story. This person had a fusion from their tailbone all the way up to their shoulders and their spine. Probably, I know it's probably for scoliosis, sagittal balance. The surgeon probably convinced you needed it. And now you're having what's called junctional failure, where right above the fusion you're starting to fail. What you need is a CAT scan, an MRI, x-rays, and then set up a consultation. Use the link below, and you can mail us your images. And I don't mean email, I mean send your images like a CD with your images from the imaging center. You have to mail it to Duke Spine MRI Review. Okay? You got to go to the imaging center. You have to ask them to make a copy of all your images and put them on a CD, and then you need to mail that CD to Duke Spine. And you got to fill out the form online, the virtual consultation form. And I will tell you why you're having pain. I will diagnose your pain on a Zoom call where you and I will sit there and I'll look at you and I'll be able to examine you over Zoom, okay, virtually, over your computer. It's very easy for me to do that. But I need you there, and I need to see your images, your CT, your x-rays, and your MRI, okay? And then I could tell you exactly what's wrong. And I could tell you how to fix it. And of course, I can fix it for you if you want me to. A lot of people don't realize, but I am also a fusion surgeon. I don't recommend it when you don't have to have it, but some cases you have to have a fusion done. And you may be one of those situations. We're just about done at this level on the right. This again is L4-5. My opinion, much worse than the L5-S1. Older injury. And what you're seeing, just so you all understand, this is the disc down here. This is the back of the disc right here in the back where the laser is. This is the fat in the epidural space. And the nerve is going to be just behind these pieces of ligament. Those are ligaments. They're called foraminal ligament. And they come off of what's called the ligamentum flavum, which is the yellow ligament that we all see as spine surgeons. And this is the lateral projections of that ligament. All right, just about done. Just a lot of herniations here laterally still I'm working on. What other, did you put the link for the virtual consult, Duke Spine?
Yes, we did.
.com
Yep.
/VC.
Yes, we did. And yep, the next question we have is from Sean Wilson, once more on YouTube. And they asked, have you had any laser surgery yourself?
Have I had laser surgery myself? No. Great question, though. Lasers are definitely getting to be more popular in medicine. We're using them for brain tumors. We're using them for epilepsy treatments. We're using them for lots and lots of things in neurosurgery. People are starting to understand just how valuable lasers can be in microsurgery. So I've not had laser surgery. I've had sinus surgery. I've had my sinuses operated on and fixed. Took 3 surgeries. I went to who I thought was the best, and actually in the end, I'll be honest with you, I had to diagnose my own problem because the surgeon didn't believe me when I told him that my airway was obstructing, closing at night, and I thought it was my soft palate. And he finally, you know, after doing 2 surgeries that didn't fix it, he did his 3rd surgery and it fixed it. And I'm very grateful because I literally thought I was going to die in my sleep. It was so bad. But I had it done. And the funny thing is, my insurance didn't pay for it. They said it was experimental, unnecessary surgery. So those are some of the things we talk about all the time here, how insurance companies always try to get out of paying the bill by calling things experimental, even though they're not.
That operation's been around for many years helping people.
right? The operations,
Comment experimental is really false because it's been around and
yeah.
people for many, many years.
So Dr. Berndes says to make the comment that it's experimental is false. What they're doing, though, is they're saying the surgery is not experimental, but the indications are experimental. In other words, the reason you need it is experimental, right? It's not proven. That's what they're saying. And there's nobody challenging them. They're just doing whatever they want. And what they want is to not pay. So it's just going to get worse. All right. Just about done. I'm going to be done in about 10 seconds here. Clean things up really good. Gotten rid of all the herniation at L4-5. On the right side, just a tiny skim left right there. See if I can make it better. Remember, my goal is not to get rid of 100% of the herniation. It's to get rid of all the herniation that's causing symptoms. People ask me, can you get rid of bone spurs with the laser? The answer is yes, I can, but I'm not going to get rid of all your bone spurs. I'm not going to attack everything just because it's there. I'm going to attack only strategically what needs to be attacked and fix only what needs to be fixed strategically. Remember, back pain is not a structural disease. It's an inflammatory disease. The problem is all these surgeons are trying to make it a structural disease. It's not.
Lights on, please. Thank you.
All right, we're just about done here with that. I'm going to irrigate with some betadine antiseptic. Questions?
No current questions, but we do have a comment from Vichithra once more on YouTube.
Okay,
And they said,
watch it.
please let no cost for operating. Please let me know when you come to South Africa.
Thank you. I'll be there in June. First time in South Africa. I'm very excited. I've seen so many pictures, and I'm going to be going to Botswana as well. So I'm going to spend a little bit of time in Botswana. It's been a dream of mine for 30 years to go to Africa, and so it's the first time I'm actually going to be able to go. I hate to say it, but you'd think going to Africa is not expensive, but it's actually very expensive. So, but my kids are getting to be an age where they're going to start leaving, and I want to make sure that I take them to Africa at least once before they grow up. Yeah. All right, I got it. Our last on the right side will be L3-4 shot. Shot. All right, so we've been able to do everything through one incision at here on the right side. And for those of you who don't know, this is the dilator. Can you see this, Henry?
Yep. Yes, we can.
And you can see the tip of it is very small. Tape measure.
Tape measure is over there. Tape measure, please.
Never mind. And we're going to take this tip right down the dilator, the guide wire, into the herniation. So we're going to take an X-ray picture, shot. You can see it passing, shot. And now you can see the tip of the dilator at the back of the L3-4 disc. We've gone through the foramen, called transforaminal. And again, this part of the surgery right here, this whole transforaminal approach with the dilator and the guide wire, I did not develop this. This was taught to me by a very special surgeon, Dr. Anthony Young, who's retired now. He's a Chinese orthopedic spine surgeon, practiced in Phoenix. He was a pioneer in the world, trained by Parvis Camden out of Pittsburgh, who was the first spine surgeon in the world to do a transforaminal endoscopic surgery. And then Dr. Young taught me, and I've known his son, Chris, since our UC San Diego days, back in the 80s and 90s, early 90s. His son followed his footsteps, became a orthopedic spine surgeon as well, but he actually, last time I talked to him, he was very much into doing metal surgeries. So didn't really, in my opinion, appreciate everything his father had accomplished to reduce the invasiveness of spine surgery. All right, any questions?
No current questions.
Let's run our video. Take your time. I don't want to break the fibers. Can you buy more of these?
Oh, yeah.
Yeah.
Actually come with a camera, 600.
I wonder if they sell them by themselves, no? What is going on here? All right. Just getting our house in order. Light on, scope on. All right. So go ahead and run the video on why does a disc cause pain? How does that happen? We got nice pressure on the irrigation, by the way.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
All right, so we're working on the right L3-4 disc herniation. And once again, if I were to ask you, hey, looking at this disc, can you tell the difference between L3-4, L4-5, and L5-S1? The answer is no. You really can't. They all look about the same. They all have this blue stuff that's the nuclear material, nucleus pulposus. They have the all the scar tissue. It looks like teddy bear fur right over here. That's scar tissue. It's from chronic inflammation within the tear. They all have pretty much the same appearance. And let me just make a point to you that a lot of people think a herniated disc is a one-time event. It's not. It never is. It almost never, it's never a one-time event. Okay? If I take 1,000 people with herniations, how many of them will be a one-time event? 0. If I take 10,000 people with herniation, how many of them will be a one-time event? Maybe 1. Okay? So what's a one-time event? One-time event means I was perfectly normal, I had normal discs, I did something, and then I got a herniation. Okay, it's not that way. Herniated discs occur in sequences. And the first sequence is something called an annular tear. That's where you get a tear in the annulus or the wall holding the nuclear material in. You guys saw that in the video, right? You saw the annular tear. Am I right? Let me hear an internet yes.
Yes.
Yeah. So the first thing is tear the annulus. That opens a passage for the jelly to escape. And all it takes is some pressure on the jelly, which comes from bending, lifting, twisting, just regular activities. That pressure on the jelly pushes the jelly out. And once you push the jelly out into the tear, then you're going to create inflammation and pain. So it's really multiple steps, but once you get a herniation stuck in that tear, it never closes on its own, folks. It's done. You need the Duke laser disc repair. That's the only surgery in the world that will help your disc heal naturally and stop herniating in the future.
We have another question.
Yes.
This comes from Austin once more on YouTube.
Uh-huh.
And they ask, I believe earlier you mentioned you also perform traditional spine surgery.
Yes.
Comparatively, how many traditional spine surgeries do you do relative to the minimally invasive spine surgeries with the laser?
Yeah, great question. So today in 2023, I am 95% laser surgery and plasma surgery for the facets. I do about 5% traditional, and every surgery I do, I broadcast live. So you get to watch it every week. If you go to our YouTube channel of Duke Spine Institute, and you go to the live LIVE button at the top, when you hit playlists, you'll see we have literally thousands of surgeries going back for years and years. And you can watch all my fusion surgeries, my carpal tunnel surgery, not my carpal tunnel surgery, but the ones that I do on patients. So we have all of that online. And the reason I did that was because I truly believe that the doctors that want to learn the best way to do spine surgery and neurosurgery will go to our website, our YouTube channel, and they're going to be able to watch those surgeries and improve their technique and become better surgeons for their patients. And that's my goal. My goal is for everybody in the world to have the best surgery they can possibly have, which of course is what we do here at Duke Spine. And I want their doctors to know how we do it so that their surgeon can do it for them, even if they can't come to me. That's why we broadcast everything. And that's why we have a repository. We save our videos, we make them visible for everyone. We also do the live stream so we can answer questions for people. And, you know, I'll be honest, as a neurosurgery resident, the thing that you look forward to the most in neurosurgery or any spine or any surgical field is, every resident will tell you the same thing. They want to get in the operating room and learn how to do surgery. After all, that's why they go into surgery, is to become a surgeon. Well, the truth is the training programs don't let you learn how to do surgery until you've spent several years working as a modern day slave for them, taking care of patients on the floor and doing all the work that nobody else really wants to do. So the higher up you get in your training program, the more you get to go in the operating room and watch surgery and assist. Now, I can't let you guys assist yet, maybe someday, but I can at least put you in the seat next to the surgeon, which is what the most valued place is for a resident in training. It's being able to see what the surgeon sees. Now, because at Duke Spine Institute we created this entire broadcast, state-of-the-art broadcast system, we're letting you, the entire world, be in that second seat, that passenger seat, that normally is occupied by a chief resident, a 7th-year neurosurgery resident, the top, the person who's already put in 5 or 6 years of dedicated work and is being rewarded after all that servitude. They're being rewarded by being able to watch the endoscopic view, being able to be in the operating room and see what's happening, how the surgeon treats the patient. That's how they learn, through observation. And I've given you guys that chief resident view through broadcasting my surgeries for the last 10 years here at Duke Spine Institute, so that you all can be the chief resident without actually having to work 110 hours a week for 6 years, like I did. in the hospital to earn that right to stand there and watch the surgery, because that's really what your investment is. 7 years of 110 hours a week working so that you can stand here and watch this surgery like you guys are sitting watching right now. Anyway, that's something we don't talk about much, but it's important to point out. So to answer your question, I have a lot of surgeries. They're all archived, but today, in this 2023, 2022, about 95% of my surgeries are endoscopic or plasma, which is two new technologies nobody else in the world knows how to do. So, and then I could still do fusions. I did one the other day. I did one a couple of weeks ago, lumbar fusion, 2 levels. Patient did great. By the way, all of our fusions are outpatient. Patients go home 2 or 3 hours after their surgery is done. We don't keep anybody in the hospital. They all discharge within 2 to 3 hours of their surgery. All right, this is the top of the tear, the most outer part. You can see how torn it is and frayed. Yep. I should be done in about 5 to 10 minutes here on this side. Then I got to go to the left side and do the left side. This patient traveled to us from out of state, and he wanted everything done in one shot. So we're not spacing anything out. We're just getting it all done today. And that's going to be 4 disc herniations and tears fixed. How's our patient doing?
Very well.
You guys can see how precise the laser is. It only affects tissues right at the tip. It doesn't just shoot around the room like everyone says lasers are dangerous. They're not dangerous if they're used properly. Of course it's dangerous if I don't use it properly. I could hurt somebody, the patient, the surgeon, me, I'm the surgeon, or my assistant, Luis. But Luis has been working hard lately, so I have no intention to hurt him. Other days, on the other hand, I'm just kidding. I'm very, right? Whoever misbehaves, I'm going to go Negan on them. All right. Negan. If you know The Walking Dead, you'll know who Negan is. He's the really bad guy. Yeah, he's got Lucille. And I guess I have to name my laser at some point. After 16 years, I've never named a laser.
Major laser.
No, I'm not Major Laser. Terminator? I like it. I like it. It's homage to Arnold. The problem is with the Terminator is that there's been all these, future renditions, right? Like future Terminators that keep getting better and better. Or worse and worse, I guess. Perspective. No, I got to come up with something else. Lasinator? Something like Fuego. Fuego. Huh? El Lasador. All right. Well, we're taking suggestions from our audience on what to name our laser. So we'll leave it open for a few weeks. Huh? Dukinator? Huh. Oh, Duke Nukem. All right, we'll leave it open. Any questions right now?
Yes, we have a question from Sarfraz on YouTube once more. And they asked, Doc, does herniated disc cause sleeplessness and sort of uncomfortableness all the time?
Yes. Yes, it does. Herniated discs, if they're causing pain, are going to make it difficult to sleep, make it difficult to do everything. Work, sports, anything. The people with herniated discs, they can have zero pain or they can have excruciating, unbearable pain. And I've seen it all. It just depends on the individual. If you have zero pain, maybe you don't do anything. You leave it alone. But if you're having discomfort in that area, it can definitely cause sleeplessness. Now, if you've had treatment for your herniated disc, like a steroid injection, the steroids will definitely cause sleeplessness. That's one of the biggest side effects of steroids is inability to sleep, having bad dreams, agitation, anxiety, palpitations, redness, swelling, weight gain, water retention. So if you're treating a herniated disc with steroid shots, those are some of the bad things you'll get with steroid shots.
We have another question.
Sure.
Two questions. This first one comes from Loretta on Facebook, and
Hello, Loretta.
they ask, can a disc tear completely in half?
Can a disc tear completely in half? Yes. Yes, it can. Yes, it can. Absolutely. So the tear, you're seeing the tear was right here, and I'm holding the tear open with the tube. But this tear can go all the way around the disc. They call it a circumferential tear if it goes all the way around. It can go around the entire disc circumference. All right, almost done.
And we have another question.
Yes.
This comes from Oz on YouTube,
Hello, Oz.
and they ask, what are we looking at?
Oh, so we're looking inside the disc. So as a matter of fact, let me see if I can help you. We're coming from the side of the disc, and we're looking at the outside of the disc is right here. There was a giant tear, and we cleaned the tear with the laser. That glass thing is the laser. It has a blue coating around it, plastic coating, but the glass fiber transmits the laser energy from a machine here in the operating room by the patient's feet. It's about the size of a giant suitcase, and that laser energy is transmitted through a glass fiber, you know, like fiber optic fiber. It bounces around the fiber until it gets to the end, and then it comes out. And I direct it to where I want it to go. So you're watching me like point it to tissues and touch those tissues, and as soon as I touch the tissues, they break up into little pieces that are microscopic. You can't even see them. They're so tiny, but see how it just, everything shrinks away from the laser, it just disappears? That's fragmentation of the tissue. So that's what the laser does. It precisely breaks up the tissue. All right, just about done here. So we're just about done. We're cleaning out a herniation. Let's go ahead and run the video of the Duke laser disc repair, lumbar, while we're switching sides, okay?
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
Hey Oz, so hopefully you were able to see what it is we're doing here with the laser. Basically we're repairing the torn disc where the herniation comes from. And I'll show you in just a minute. But can you guys see the back here?
Yes, we can.
So basically, this is the middle of the back. The buttocks are right here. The head is up there. And most of his problems were herniations on the right side. So we fixed literally 3 herniated discs with 1 cut. Look at the size of this cut. You have a ruler?
Do we have the ruler, Oscar? No, we don't.
Okay. So you guys see this? It's 7 millimeters.
Yes, we do.
We did 3 discs. I just went in this way, did the bottom, then the middle, and then the top. And now we're going to go onto the other side. Yeah, we're done. And we're going to do one more repair on the left side because he's got left leg pain also. His worst is definitely the right side, but he's also got left-sided leg problems. And for him, like many people, the leg symptoms, they come and go. But now he's got weakness with the the right foot, and he's not able to bring his foot up. So he's got a drop foot. So this is not so much a pain surgery as it is a unpinch his nerves that are getting pinched badly. Shot. Shot. All right, you can see the guide wire inside the disc. Now I'm going to take shot. I'm going to take the needle out and leave the guide wire. Shot. Yeah. Okay. I'm going to give some more num-num. We're just about 15 minutes from being finished on this surgery. And once again, this patient had 4 herniations fixed. And what I mean by that, we removed 4 herniations, L3-4, L4-5, L5-S1, plus we cleaned the tear where the herniation came from so that it won't come back again. And it gets rid of the back pain. All right, you have any questions?
Yes.
Shot?
From Oz, they said, thank you. Also, if you get a surgery,
Shot?
will you get adjacent segment disease as a guarantee in the adjacent levels?
So I don't know exactly what you're asking as far as adjacent segment disease, but if you get open back surgery where you do laminectomy, discectomy, fusions, artificial discs, those surgeries cause adjacent segment disease, meaning you're going to have to come back and get more surgery at the disc or facet joint above or below where you operated. That's called adjacent segment disease. But with the Duke laser disc repair, there is no adjacent segment disease. We've never had a single case of adjacent segment disease in 1,600 surgeries. Not a single case. Yeah, I agree. That's another study. We've got so many studies. I just can't keep up with them all. Yeah, because this is new technology. We're changing the way spine surgery is done, and our results need to be published, but you know, it's just hard for me. There's only so much I can do. Running a company, trying to keep it financially fungible, you know, and doing surgeries and developing new technologies and raising kids, teenagers of all things, which are so hard to bring up because they take a lot of time, those kids, a lot of energy. If you care about your kids, they do. If you don't care about your kids, it's easy. You just, there's the street, go play. You know, don't bother me, right? But if you want to do parenting properly, you got to get involved in everything. And yeah. So having the time to do all the research and publishing is really difficult. All right, we're now on the left side at L4-5. And I'm just waiting for things to clear up a little bit. You can see a tear. And I'm going to start cleaning that tear. That tear has been there for probably 30 years, and it's never healed itself because it can't. Because the jelly is stuck in the tear. Apologize for the poor visibility for you guys. It's bad for me too, but the good news is I've done this a couple of times, so I know what needs to be done. I'm able to fix it without seeing that much. I have something called the mind's eye. How many people know what the mind's eye is? Anybody here? The mind's eye. Nobody. Are you guys kidding me? Huh? The mind's eye. The mind's eye. Yes, visualization. You're well, the third sense. I don't know about the third. I think I have more than. Yeah. That's correct. So can you see your car right now in the parking lot, Oscar? Imagine it. Just imagine it in your mind. Think about where it is, the color, the shape. Did you park front end? Did you back in?
Back in.
Right? And did you see the fence behind it?
Yeah.
Okay. Do you see the sky above is blue or cloudy? That's the mind's eye. It's the ability to see even though you can't see. You use your memory, your perception, your experience to visualize. So I use that when I can't see very well because it's a little bit of blood or whatever. And I can see myself and using the laser to destroy these bad herniations and remove them.
You have about 10 minutes?
Yeah, 10 minutes. Mm-hmm. I don't know. You have to meditate. You have to be able to have what's called an out-of-body experience. And not everybody is taught to do that. I was taught to do it. An out-of-body experience is where you leave your body and you journey out into the world or the universe, wherever you want to go. Some people call it daydreaming. Daydreaming is a form of out-of-body experience. I did a lot of that as a kid. I got into a lot of trouble at school because of it. I was always daydreaming, visualizing. Anyway, it's a very important tool to use in life. I used visualizations in medical school to help remember all the things I had to remember. Medical school is basically a situation daily where you're in class and you're expected and asked to remember absolutely vast amounts of information. And when I say information, I don't just mean, information like red, blue, things that are simple. You have to understand relationships over time of not just structure, but physiological things that you can't see, things that happen without structure, like biochemical things. And pharmacology is an example. You have to be able to visualize, to be able to remember the relationships, the uses, the way drugs work, the way the body works. And that doesn't happen overnight. That's something that takes many years to develop a foundation for learning for medical school. And that's why medical schools are very selective. They only take the top students, the students with the best grades. Why? Because they realize how intellectually demanding medical school is with all the memorizing and understanding you have to do. And they select for people that will be successful at that because it's very demanding on your time and very demanding on your mind. You have to basically give up everything else and focus just on learning And that's what I did. And that's given me a great foundation for improving medicine where I can. You can't improve unless you know the limits of what already exists. And to know the limits, you have to understand medicine, and if you want to improve medicine, that is. That's how I was able to develop this technology that we use today, the Duke laser disc repair, because I learned the limits of our existing technology and how it failed and how it succeeded. And I took the best qualities of what we do today and I modified to make it better. All right, we got 5 minutes left.
We have another question.
Sure.
This comes from Sarfraz once more on YouTube,
Uh-huh.
and they ask, when can we see this patient talking again?
When can you see this patient what?
Talking again.
Oh, well, great question. Well, you won't see them talking, but I will in an hour. I mean, not even an hour. So we're going to finish in probably 5 minutes. Then we're going to take the patient from here to the recovery room. We're going to put them on a gurney, wheel them out. Within 10 minutes, they'll be talking. Okay? Because the medicine we use, propofol, is the very best, and it allows people to wake up very quickly. As a matter of fact, when I have my colonoscopy procedure, they use propofol, huh? Yeah, it's the same. Oh yeah. And they always tell me before my colonoscopy, they tell me you're going to have to go home and take it easy all day. And by 2 hours later, I'm working again. You know, I'm not with patients, of course, but I'm doing work, you know, administrative duties. So, point I'm trying to make is the medicine we use is so advanced that it wears off within minutes, and the patients are back talking within minutes. As far as being able to see these patients, you see them. They're on our YouTube channel. All you have to do is look at the testimonials. Can you put the link to a testimonial, or actually, better yet, why don't you play a testimonial, and that way our audience can actually see one of these patients right after surgery the next day when they're coming in and telling us how wonderful they actually feel. Oh yeah, no, their pain is gone usually within an hour. They wake up and they know their pain is gone. They may have some soreness from the procedure, but they're up talking to us and to you within 24 hours. And that's what those testimonials are. So Henry, will you put a link to our lumbar testimonial page, the playlist? And then, of course, if you could run a testimonial as soon as I'm done, that would be great. And I'll be done in 1 minute.
Copy that. We also have a comment from Vichithra, once more on Facebook. And they said, please let us know when your address in South Africa in June. Thank you.
You're welcome. Thank you. Thank you. I am going to go cage diving with a great white shark, in case you want to join me. That's been a dream of mine for a long time. We're done.
All right, lights on, please.
So. Huh? Thank you.
Scope out, please. Thank you.
How come we have so many Band-Aids? Can we fix that?
Yes, sir, of course. Should be on there too. Sir?
All right. Are you on the testimonial or not?
Not yet. I wanted this
Yeah,
the
no
audience
problem.
to see the
Let's
incision.
do that. We're going to show you the 2 incisions, and then we're going to cut to a a testimonial so you can see somebody who had the surgery. All of our testimonials, most all of them, I shouldn't say all of them, most of them are done the next morning before people leave because they fly away and we don't see them anymore because they're doing great. But we do have some in there that are 6 weeks after surgery, 3 months after surgery. And of course, when we looked at our back, the lower back pain ones for the Duke laser disc repair, 6 years after surgery, they had 95% of their preoperative back pain was gone from the disc. So the surgery not only works, but it lasts. It lasts. And most spine surgeons don't check their patients 6 years, but we had to call our patients and see how they were doing. All right, you can see the incisions, folks. You see them?
Yes, we do.
Tiny, 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 minimally invasive. This is endoscopic transforaminal surgery. We lost maybe 2 cc's of blood. Pressure. All right, guys, go ahead and run a testimonial, and I will come and I'll answer your questions. So type your questions up, and I'll be there in 5 minutes to answer them for you.
And I'm Dr. R. Duke Majan here at the Duke Spine Institute. I'm smiling because I'm sitting with my first surgical patient of 2023. I don't know if you realize that, but you were the first one of this year, of the new year. Now, you had the Duke laser disc repair done on your lower back because you had 3 bad discs, and we did that yesterday.
Yesterday, yes.
And here you are, 1 day later. How do you feel?
And I feel good. I feel good, and the pain that I've been suffering for months is gone. I mean, I was a little bit sore, but that's from the surgery itself.
Yeah.
But otherwise, I feel good. Feel good.
Now, you've had back pain too, on and off for 30 years. We were talking about that. Tell us about those episodes of back pain. What do they do to you?
The first one that I recall was pulling out a sofa bed thing. And I got so far with it, you know, we had company and I was opening up the bed, and all of a sudden I just could not move. I couldn't move. My husband had to practically carry me. So I was out of work for a week or so, and then at the chiropractor, and then gradually it got better, and I thought, well, that's fine. And I moved on, and then, you know, had a couple other times like that. One time I was drying my hair, getting ready for work, with the blow dryer going like this with my hair, and all of a sudden, it's like I couldn't move. I couldn't move my arm down. I couldn't, I mean, it was that quick.
Yeah.
And just, I was out again for another week, laying in the bed and doing all that stuff. And then I thought I was fine, but I always, not always, but for many years now, probably at least those 30, I had lower back pain, where in the morning I couldn't bend over to brush my teeth. You know, that would really hurt.
Yes.
So I had that.
Do you have that pain now?
No, I don't think so.
It's gone.
The pain this morning, I was the first time in a long time I've gotten up first thing in the morning and was able to walk and not have that awful pain, because first thing in the mornings was the toughest.
I'm so happy for you. So how is this surgery going to help you in your life?
Well, hopefully I can, once I can at least walk again. I was not able to barely walk with a walker. I was very active in my church, in my community.
So you want to get active again?
And being in such pain now since July, and this is the new year, I'm anxious to get back to, you know, my life.
Yes, of course. Well, you had 3 herniated discs in your lower back, and you can see in the footage where we went into each of those 3 discs, and I used a laser to clean the tear, where you had a tear in the back of each of those discs called an annular tear, and the jelly from the center was stuck in the tear, holding it open, allowing more herniations to come out. So I got rid of the jelly that was in there using the laser, cleaned out the tear, and now your body will be able to heal that for the first time in 30 years. So I don't expect you to ever have that pain ever again.
Thank you.
You're welcome.
I am so thankful.
Well, you had faith and you found us.
Yes, I did.
You did what's right for your body, and I'm excited for you. So
I believe I did. I just kind of was led to you, and it just all went bing, bang, boom, and I didn't ask a whole lot of other people what they thought. I just did what I thought was I needed to do.
Good.
For me.
Is there anything you want to say to your fans out there?
I would recommend that if you do something to your back, that you take care of it early on. You take care of it right away. The longer you wait, the harder it is and the longer it takes.
Takes a toll on your life.
Oh, definitely. It has taken a toll on mine since this summer, for sure, where I have not been able to sometimes not function at all, barely be able to sit in a chair and be comfortable without squirming because I couldn't find that exact place where I didn't have pain. You know?
I don't see you squirming anymore.
No, I'm not squirming. I know. That's great. Sit here without pain.
Congratulations.
Thanks to you.
All right, have a blessed day.
Thank you. You do as well.
Good morning, I'm Dr. Duke Majan. I'm here with one of my patients and friends who I've known for years, and she has been suffering with back pain for, well, I'll let her tell you how long. And a week ago, she came and had the Duke laser disc repair. She's here for a checkup, and I'll let her tell you how she's doing as well. So how long have you had your back pain for?
Started back in May last year, and I just couldn't get any relief from anyone. Finally, I asked you, and the rest is history. So this last week has been the best week of my life since May of 2022. So pain-free.
Excellent.
Yeah.
Now, I know it got bad last year, but did you have back pain on and off before that?
I did. I actually got thrown from a horse back in 2018 in Ireland. And that's what I think probably started it. I was having lower back pain, but never really did anything about it, just sort of lived with it.
Kind of modified your life, took
Yeah.
it easy, try to avoid things that aggravated the pain.
Exactly.
And now I know that you were suffering so badly before the surgery, and here you are with a smile on your face.
Oh yeah,
Yeah.
definitely.
Well, I'm so happy you're out of pain. You had the Duke laser disc repair. You could actually see, we use a laser to clean the tear in the back of the disc where the pain comes from. The problem is most doctors don't know that's where the pain comes from, so they have no idea how to fix it. My years of doing endoscopic surgery taught me that that's exactly where the pain comes from. So it's a small little spot in the back of the disc. You fix that, the back pain goes away.
And it worked.
It's amazing.
It's like I told your wife, you're a miracle worker.
Oh, thank you very much. Is there anything you want to say to your fans out there?
I just highly recommend if you've had back pain in the past, don't live with it anymore. Call Dr. Duke. He is the best.
Yeah, so many people's lives are just, quality of life is ruined by back pain.
It is, and not worth it. I'm ready to start traveling again, so.
Not too much too soon.
Not too soon, I know.
All right, very good, Jean. Great to see you.
Alrighty, thank you so much.
You're welcome.
I appreciate
Great
it.
to see you.
You too.
And good morning, I'm Dr. Duke Majan. I'm here with one of my lovely patients from Canada who's visited us because her back has been hurting for 7 years. She's had a herniated disc that she's been kind of monitoring at L5-S1. And finally, it really started bothering her a lot over the last 7 months to a year, causing pain down into her right leg. So she decided to do something about it, and she went to see her doctor in Canada, who then said, yeah, I'll have you see the specialist in 3.5 years. Well, that wasn't going to work for you, right?
No.
Yeah, because you don't want to live in pain for 3.5 more years. And even then, you don't know what you're going to be offered. But she found the Duke Spine Institute and learned about the Duke laser disc repair, endoscopic surgery, and you had it done yesterday.
Yes, yeah.
How are you doing?
I'm feeling great today. I have no pain in my back. I have some tight muscles from me having to walk very oddly for quite a while due to the sciatic pain. I must say, this is the happiest I've been in a very long time to be able to stand up straight and go for a walk. Because I'm an active person as is. I ride horses for a living, so having to be locked up in my room for the past while has not been good. So this has felt amazing, amazing.
So you're happy with the results?
Very. I feel very hopeful also to be able to do what I want to for the rest of my life.
Yeah, after we let the disc heal, right?
Yes, full year of nothing, and then we can.
Yeah, I wouldn't say nothing, but you know, horseback riding, it's one of those things where I love horses and I love riding horses. I'm not very good at it, but I'm one of those people you see bouncing up and down, up in the saddle. So I know that it can be rough on your back, and I just want to make sure you give your back a full year to heal. So you can see in your surgery right here, we actually tested your L5-S1 disc with a discogram, which is a test done to verify that that disc is indeed causing your back pain. And when we tested it, you said, and we asked you how bad it was. You said 10 out of 10 pain. And I said, is that your typical pain you get every day? And you said, yes, it is. So we verified the source of your pain was the L5-S1, and you can see the laser was used to clean the tear endoscopically. Your incision was only a 1/4 inch, and there's no need for fusion or metal or artificial discs. This surgery replaces fusion and artificial discs. What are you going to do now that you're feeling better?
Well, it's, again, don't worry, I will take it easy, I promise. But no, I'm going to be, after this, this year, I hope to be the strongest I've ever been. And I have very high hopes and whatnot. My dream is to make actually the Canadian Olympic team for my sport. And that's end goal. And I feel like it's a possibility now.
Absolutely.
Do it.
You can.
Yeah.
We're rooting for you. And I know you have an incredibly supportive husband who's been by your side the whole time. He's a delightful young man, and I've had time to talk to him as well. So you're lucky you have support from your family to help you get through this.
Yeah.
Anything you want to say to your fans out there?
Oh, geez, I don't even know where to start other than just this place really can offer you really what either you deserve or what you need going forward to be able to live a happy and good life. And it's amazing to me that literally it was yesterday I woke up from it and I went for a short walk like immediately, and I felt amazing. So it's it's very hopeful. And if there's you are suffering from any of it, don't wait, especially for the Canadian system. Come and do this. It's worth it. It's really worth it.
Awesome. And I'm going to be, and my whole team is going to be watching the equestrian sports in the Olympics, looking to see for you to be there.
Yes.
All right.
Awesome.
And
Amazing.
of course, supporting you.
Thank you. Yeah.
All right. Congratulations.
Thank you.
All right. Take care. All right. We have just completed our first surgery for today, February 28th, 2023. And today I think is the last day of February, right? So last day of February, we've just completed our first surgery, which is Duke laser disc repair for 4 herniated discs, 3 on the right side, 1 on the left. And this patient had 2 problems. One, the herniations were so big they were pinching his nerves going in his legs, so they were causing nerve damage. He was getting weakness with his foot and on both sides, and the other problem he had was back pain. So the Duke laser disc repair that you just watched fixes the back pain from the herniated disc. It also fixes the pinched nerves, which cause weakness, numbness, and sometimes sciatica pain down the legs. The surgery went perfect. We didn't have any complications. Everything went very well. We were able to fix all 4 discs without incident. I was able to do 3 discs on the right side with a 7mm incision. We did 1 disc on the left with the same size incision. The reason the incision in the skin is 7mm is because the tube that I use to go in is 7mm, and it's tapered. As you could see, the dilator was tapered. That allowed me to pass through the muscle and tissue right to the herniation, and then we use the laser to zap it away. At the very beginning, we saw a beautiful inflammation happening in the wall of the disc. That inflammation is there because of the herniation. I believe that because that inflammation was relatively acute, meaning it's happening recently, that L5-S1 disc where we saw it, that disc was probably a more recent herniation. And when you look at the insides of the disc, it looked to me like that L5-S1 was probably the most recent herniation. The L4-5 is much older. The L3-4 appeared to be old as well. And once again, herniations, when we get to them and treat them, typically there's already been 20 herniated fragments inside the herniation. So when we talk about a herniation, it's not one herniation. It's got at least 20 on average pieces of herniation in there, which means there have been 20 or more events in life where that patient was bending over or lifting something and squeezed out another piece of herniation. Very common problem. All right, we have some questions and then we'll get to those, and we've got one more surgery after this. This will be the next surgery will be a patient who has really bad neck pain, and whenever he turns to the right or left, he gets horrible pain at the base of his neck and at the top. And we're going to be going in doing what's called the Duke plasma rhizotomy, where I will be going in and deadening the pain nerve at several joints using our new technology that's basically in the process of being patented, and that is the plasma rhizotomy. We're going to go deaden the pain nerves there on both sides. All right, we'll take our first question.
First question comes from Oz. What is the name? Oz from YouTube, and he says, what is the name of this kind of surgery, and can it be done for all kinds of disc herniation or bulges?
Yes, Oz. This surgery is called the Duke laser disc repair. It's been published that way. If you go to the National Library of Medicine in the United States, you can look up Duke laser disc repair, spelled D-E-U-K, and we have several peer-reviewed publications. And it can be used to treat any disc problem that's causing symptoms.
Next one comes from Vichithra, from South Africa, on Facebook, and they ask, can we make an appointment with you? Thank you. I don't know if that means for here in Florida or when you decide to go to Africa.
Yeah. So we have a viewer from South Africa, and I mentioned I'll be there in June of this year. You can definitely make an appointment, but I'm not going to be in South Africa seeing patients. I'm going to be there with my family. So I won't see patients in South Africa, but you can see me virtually, just like you are right now. And I will be able to see you on my computer screen. And I will be able to diagnose the cause of your back pain or leg pain or neck pain or arm pain, whatever's ailing your spine. I'll be able to make the diagnosis. It takes me 5 minutes to figure it out. And I'll ask you a series of questions. You'll give me the answers, and I will tell you exactly why you're having your symptoms, okay? And then I'll tell you exactly what needs to be done. So yes, we can do that. It's a virtual consultation. We've been pushing out the link. We'll put it again right now. We'll post it on the response, but it's dukespine.com/VC for virtual consultation. All you got to do is fill out the questionnaire and get us your MRI images and your report. Usually you can take it from your computer and sweep it in to the web portal. If you can't do that, then you need to go to the MRI center and get copies of your MRI images on a CD and mail that CD to us by UPS, FedEx, or some type of a mailing company, not internet. We don't accept the images over email. It's too large of a file. All right, if you do that, you get your MRI review and you get a diagnosis, and then you can get fixed. The other option is just come here to Florida, come straight to Duke Spine Institute. We've had patients do that. We've had patients show up and say, I'm not leaving till you fix me. And then of course we do their surgery and they get fixed and then they go. So we've had those patients as well. But it just depends on how motivated you are to get rid of your back and neck pain. We can do it immediately if you come here.
All right, 3 more questions. These next 2 come from Oz on YouTube, and he asked, is this endoscopic procedure covered by health insurance, and how do you know if a herniation is old and or acute?
Hi Oz, couple of questions, great questions by the way. I love your questions, so please keep coming back and asking them. So the first one is the surgery covered by health insurance? The answer is yes. And sometimes it's hard to get the health insurance companies to pay, and we have to fight them. Other times they just pay. The way you get, as a provider, the way we get consistent, reliable payment from an insurance company is to have a contract with that insurance company. And Duke Spine has contracts, but the surgery center where we do the surgeries, like a hospital, it does not have contracts with most insurance companies. And so because we don't have contracts, we don't know if the insurance companies will pay for the surgery center. And that's the big cost. 90% of the cost is the surgery center. So to answer your question, yes, the insurance company should pay, but we don't know that they will, and unless we have a contract with them. So, for example, Blue Cross Blue Shield is our biggest insurance that we deal with. Most patients have Blue Cross Blue Shield or Anthem, and we will bill Blue Cross, and many times they will not pay, and we will appeal the decision, and then we will fight them. And we have a class action lawsuit that we're getting ready to do with Blue Cross Blue Shield because they're not paying bills when they should be. So a lot of the times we have to sue the insurance companies. Unfortunately, we have to use the court system to have them do what they're legally responsible for doing, which is paying the medical bills for necessary medical care to help people. And it's not unique to Duke Spine Institute. These lawsuits by hospitals, by doctors are happening all the time because insurance companies misbehave, and they will misbehave on purpose. They will not pay on purpose. They will do it because they'll see if they can get away with it. And if they get away with it because nobody's paying attention, well, then they're going to save $100,000 on a surgery that they didn't pay. And that goes to their profits. And their people are bonused based on the profits that they get. So they're incentivized not to pay our bills. And they'll do everything in their power not to pay. Medicare will not pay for the surgery if you have Medicare. Medicaid, I would not expect Medicaid to pay for the surgery. But the vast majority of commercial payers should and will pay for the surgery. As far as how do you know if the herniation is old or new? There's different ways to tell. One of them is, let's say you got an MRI a month ago, you didn't have a herniation, now you have an MRI, there's a herniation. That would indicate the herniation's new. And that's, maybe you had a car accident 2 weeks ago, so that's why you got the MRI and saw the herniation. On the other hand, I can tell if a herniation is new, usually based on the MRI, but it's very hard. The best way to tell if a herniation is new or old is to do an endoscopic surgery like we just did. I can tell from that.
Okay. And last but not least, we have Austin once more on YouTube. And they asked, do you have data on the reoccurrence of herniations after surgery, more specifically at the spot where you used the laser?
Yes, we have recurrent disc herniation rate. It's 1%. And it has nothing to do with the laser. It has to do with people doing things they're not supposed to do after surgery, like gardening right away the next day or a week later. You got to let the disc heal. It takes about a year to fully heal. All right, we'll be back with the next broadcast shortly. We're going to wrap this one up. Have a great day.